Hello and welcome to your video lecture on the digestive system. We are going to start with section 23.1 on an overview of the digestive system. So we'll start with the function of our digestive system. Of course, first we need to ingest the food and put it within our alimentary canal. So we can call this our GI tract, the alimentary canal, our digestive system. It has lots of different names. And so when we put that into the oral cavity here, we are then going to go through the process of mastication, which literally means chewing. Here we can go through chemical digestion, in which we're able to have secretions from our salivary glands to help chemically break down these large particles of food. And we can also use a mechanical type of digestion, which is really what mastication is, in us really physically chewing up that food and breaking it apart, which is going to help to facilitate that chemical digestion. And so the next thing we want to do is have propulsion take place. So we are going to swallow that food, and along the esophagus we will go through peristalsis. These are wave-like contractions that help move that down, and then as we move into the small intestines and the large intestines, we will create more movement through peristalsis and mass movements, and also some segmentation in which we're mixing the food together, but we'll talk more about that a little bit later. So our food or our nutrients are consumed and mostly absorbed within our small intestines here. As I said in the previous slide, our digestive system has a lot of different names. And so the word aliment in alimentary canal means to nourish. And this is really going to be a one-way tube that is going to be 7.62 meters or 25 feet long. It starts at the mouth and is going to end at the anus. And let's walk through some of the organs that we have within this system. So first we start off at the mouth, like we said, and into the oral cavity. And we do have some accessory structures there that are going to aid in the breakdown of food. So in this region, we see the salivary glands. We also know that our tongue is going to help us move the food around. And then we move back into the pharynx. So the pharynx is made up of 3 different parts, but of course we are not going to put food into the nasopharynx, and so first it goes into the oropharynx and then down into the laryngopharynx, and the epiglottis, if you remember from a respiratory system discussion, is going to swing down and cover the larynx to protect the airways, and food will then move down into the esophagus. The esophagus brings it down into the stomach, and we have now transitioned from the thoracic region into the abdominal region. And from the stomach, we are going to move into the small intestines. The small intestines does have 3 different parts. I know I'm getting a little ahead of myself, but we've got the duodenum, the jejunum, and the ileum. After that, we move into the large intestines, and we see the colon here. We have various names for the different parts that we'll go through, and that brings it into the rectum, through the anal canal, and out the anus. Now, we said we have some accessory structures. Other than the salivary glands, we're also going to have the liver here, as well as the gallbladder, and then the pancreas we can see just a little slightly here. It can be found posterior to the stomach. So before we dive into all of those organs, let's talk about the histology of the alimentary canal. So throughout the GI tract, we have 4 distinct layers, starting with the mucosa here, which is the innermost layer. We are going to have our mucous epithelium, which varies throughout the GI tract. So we will see stratified squamous epithelium in the mouth, oropharynx, esophagus, and the anal canal. So you always want to think about stratified squamous epithelium really being in areas where there might be high abrasion taking place, where the food is maybe going to be a larger quantity, or the feces are larger. Then Throughout the rest of the GI tract, we have simple columnar epithelium. We'll also have loose connective tissue here, known as the lamina propria, and we have a layer of muscle known as the muscularis mucosa. And you could see that pictured over here. This is made up of smooth muscle, so it's going to be innervated through our autonomic through our autonomic nervous system, specifically our enteric nervous system. So I just wanted to show you some of the variability here. This little schematic here shows you the 4 different layers. So first we have the mucosa and what we just talked about, having that epithelium layer, the connective tissue lamina propria, and our muscularis mucosa layer. All 3 of these are a part of the mucosa. The second layer is going to be the submucosa. Third layer is the muscularis propria, or it's also most commonly referred to as the muscularis externa. See the spelling there? And then the last layer is the adventitia, or the serosa. So here's an image of the esophagus. You could see that stratified squamous epithelial layer. All of this is the mucosa, and what we see here in the darker pink is that muscularis mucosa layer. Then we have the submucosa, which is mostly made of connective tissue, and then we have the muscularis externa. You could see it's thicker, and we actually have 2 layers of muscle here. And then lastly, the adventitia, which is also made up of connective tissue. So you can compare what the esophagus looks like in comparison to the stomach, the small intestines, and the large intestines. But in here we are going to have similar layers, such as the simple columnar epithelium, and then all the other 3 layers. So here's another view of the mucosa. This one happens to be in the small intestines, and we could see the simple columnar epithelium lined up over here with the lamina propria layer just right underneath that. And then we have a special structure known as the lacteal. So we're going to talk more about the lacteal later on, but just wanted to give you an idea of what that mucosa layer looks like. And then we have our muscularis mucosa here as the last part of that mucosa. Now let's move into the second layer, which is the submucosa. And our submucosa is going to be, like I said, made of connective tissue, a thick layer of connective tissue. We're going to see nerves here, blood vessels, some small glands, and a parasympathetic submucosal plexus. So keep that name in mind, the submucosal plexus. This is also known as the plexus of Meissner. And then our third layer is the muscularis layer. Like I said, it's usually called muscularis externa, and it can be made up of 2 or 3 layers of smooth muscle. Typically, it's 2. In the stomach, we see 3 layers, which I'll get into later. But for the 2 layers that we typically see, we have a circular layer, meaning that these fibers are going all the way around this tube. And so when it contracts, it closes the tube or narrows the lumen. And then here we have the longitudinal layer, which is going vertically along the tube. So when this contracts, it shortens our tube, our GI tract. And here we have another nervous plexus associated with it, and that is going to be called the myenteric plexus. Myo means muscle, entero means intestines, so it's supplying the muscular layer of the intestines. When we combine this myenteric plexus with the submucosal plexus that we just learned about, it is called the enteric or the intramural plexus. And that essentially is going to help control the movement and the secretion of the alimentary canal. And here is a view of what that muscularis externa layer looks like. Here we see the inner circular layer, so the fibers are going across in this direction, whereas in our outer layer, the fibers are moving through the screen and out toward you. So you could see how they have that perpendicular look to one another, or perpendicular arrangement, I should say, to one another. And here's another view. You could see this, I think, a little bit better, where this is our circular layer. You can even see the nuclei are kind of stretched out in that manner. And here's our longitudinal layer, where the fibers are coming out toward you. Moving into our last, fourth and final layer is the serosa or adventitia, again made up of connective tissue. And this is also where we have serosa present, where we will call it visceral peritoneum. So remember, viscera refers to an organ, and peritoneum is referring to the serous membrane folds. And so this will line the organs themselves. Where we have adventitia present, we have the connective tissue kind of blending along with other connective tissue in the surrounding structures. So here's an example of what that serosa looks like. Here's the the muscularis externa layer, and the serosa is just outside of that. Whereas over here, we could see that adventitia. So this is the area of the esophagus, and so this is creating that visceral peritoneal layer. Now let's talk about the peritoneum just a bit more. The peritoneum is holding our digestive organs in place. Like I said, it's a serous membrane sac, and it is going to be made up of our squamous epithelial tissue and surrounded with connective tissue. So first we've got our parietal peritoneum. This means it is the layer that is lining the abdominal wall itself. So all along in here is our parietal peritoneum. Whereas the visceral peritoneum, that lines the organs themselves. So here we have the stomach, and this layer surrounding it would be the visceral peritoneum. Now, of course, if we've got two layers, there's going to be a space found in between them, and that's called our peritoneal cavity. So this area does contain a watery fluid, which we call serous fluid, that is going to act as a lubricant so that as we're digesting and these organs are moving, they're not going to create friction. Now, if they do, this could cause peritonitis, and that's going to be an inflammation of the peritoneum. So it could be chemical, where it'll develop anytime the canal is breached and the contents start to move into the peritoneal cavity. So this could be maybe we have an ulcer developing in the stomach, and that ulcer is going to penetrate the stomach, and all of a sudden we've got gastric juices that are spilling into the peritoneal cavity. It could be hemorrhagic, where we are going to have a rupture in something like a tubal pregnancy, meaning that there's a pregnancy within the fallopian tube rather than the uterus. Or it could be a traumatic injury to the liver or the spleen, and the peritoneal cavity is all of a sudden filling with blood. Other times it's bacterial. So we can see this with something like appendicitis, especially if that organ is going to rupture and allow that bacteria to move into the peritoneum. And then we've got colonic diverticulitis, meaning that we've got the pouches on the colon, and they can fill with fecal matter and cause a bacterial infection. And there is pelvic inflammatory disease as well. This can be life-threatening, and so you can have emergency surgery and intensive antibiotic therapy as a treatment. So let's talk about some of the major peritoneal folds throughout the abdomen. We've got the greater omentum, lesser omentum, falciform ligament, mesentery, and the mesocolon. So we'll take a look at each one of these, starting with the greater omentum. This is known as the fatty apron because it is going to be so superficial, and it lies right on top of the small intestines. It attaches to the greater curvature of the stomach and then kind of folds over the small intestines and attaches to the transverse colon. And I think this is best depicted in this the sagittal view here, where we've got the stomach. So this is that greater curvature it's attaching to, and then it's folding down and then attaching to the transverse colon. So this will be a site where we can deposit some fat in people who are overweight. So you'll see that some people have larger greater omentums versus others. We also have blood vessels flowing through this area. Then we've got our lesser omentum, so of course this is going to be smaller, and this is suspending from that lesser curvature of the stomach to the inferior border of the liver. And you could see that pretty well over here, that attachment from the stomach over to the liver, and this is providing a pathway for structures connecting to the liver. So we would find things like the hepatic portal vein through here, and some of the hepatic arteries, and also some of the biliary apparatus structures. And this is what it looks like in actuality in a person, where we see that lesser curvature of the stomach and the liver. Highlighted in green here is the lesser omentum, whereas over here, attaching from the greater curvature of the stomach, surrounding all of the rest of the abdomen here, is going to be that greater omentum. Now for our falciform ligament, we are going to see that it anchors the liver to the anterior abdominal wall. So I really like these images here where we see a sagittal view again of the body. Here is the liver, and then you could see the ligament in here attaching to the anterior abdominal wall. This is another great view of a cadaver where we see the liver. This is the right lobe and the left lobe, and here is that falciform ligament attaching to the anterior abdominal wall that's being lifted away. We also see it attaching to the inferior border of the diaphragm, so this red line here is representing the diaphragm. And then fourth, we have our mesentery. This is going to be a vertical band that is going to be anterior to the lumbar vertebrae, and it really helps to anchor and suspend the small intestines here, except for the first part, which is the duodenum. So we'll show you the duodenum in another image, but look at the mesentery, and you can see that we have lots of blood vessels in here, our arteries and our veins. Specifically, it's going to be our superior mesenteric arteries and superior mesenteric veins flowing through this area to give supply to the small intestines and then carry waste products away. And this is a nice sagittal view too, where you could see here's our lumbar vertebrae, and this is our posterior abdominal wall where the mesentery is coming down and suspending the small intestines. And lastly, we have our mesocolon. This is going to attach to two portions of our large intestines. We have our transverse and sigmoid colon. So we can see in this area where we have the transverse colon going across in the transverse plane is the transverse mesocolon. And we also have this sigmoid, which we call the mesosigmoid, is attaching from an area that we call the sigmoid colon to the posterior abdominal wall. Now let's talk about the retroperitoneal structures and what that means. For the term retroperitoneal, we are talking about the organs that are covered by the peritoneum. So anything that lies posterior to the peritoneum will be a retroperitoneal organ. So this is going to include our kidneys, which you could see back over here. Notice how this is the peritoneum, and it is lining the anterior aspect of that. We've also got the pancreas and the duodenum, which you see pictured over here. Part of this has been cut out of the way because of the level that this image was created. And then we've got portions of the large intestine. So if you look on either side, we have on the right side here the ascending colon, and then here on the left side we have the descending colon. And lastly, we have the rectum, which you're going to see better in this view here, just because it is so posterior and inferior, so it's not going to show in this cross section. But here we have the rectum, and another one is actually the urinary bladder.